Hello, everyone, and welcome back to session 5 of the Completed Life Conference. I'm delighted to welcome you today. My name is Sarah Kiskadden-Bechtel, and I'll be your host for the session, and I'm the Program Director of the Completed Life Initiative. A little bit of background on session 5. Our speakers will explore narrative as an organizing principle, as well as a tool for incorporating the elements of personal narrative that define a completed life. Our speakers today are David Hoffman and Danielle Spencer. David Hoffman is a healthcare lawyer and clinical ethicist in New York, where he is a lecturer in bioethics and full-time core faculty member of the Columbia University Master's Program in Bioethics. He also teaches in the area of law, medicine, and ethics at the Albert Einstein College of Medicine, where he holds an appointment as a clinical assistant professor. He also serves as the Chief Compliance Officer for Carthage Area Hospital. Professor Hoffman is a founding member and current secretary of the Completed Life Initiative, and we're honored to have David here today to speak about narrative ethics and narrative medicine. Danielle Spencer is the academic director of the Columbia University Narrative Medicine Program and a senior lecturer in the discipline of narrative medicine. Dr. Spencer is the author of the forthcoming Metanosis, Revelatory Narratives of Health and Identity, a book that will be published later this year by Oxford University Press. And she is the co-author of the Perkins Prize-winning The Principles and Practice of Narrative Medicine, published in 2017. So without further ado, I'd love to turn over the session to David to begin the session. David?
Thank you so much, Sarah, and hello, Danielle, and welcome to everyone in our audience. I'm really thrilled to be presenting this, the 5th session of the Completed Life Initiative Conference, Inaugural Conference. And I should tell all of you in the audience that this, for me, was really the entire purpose of the conference. It is the first idea that I had when we were brainstorming about what we wanted to accomplish in tying academic and clinical disciplines into the notion of a completed life. And my thought immediately went to Danielle, because we are not using the tool of narrative medicine and its clinical companion narrative ethics in order to fully fulfill the obligation that the healthcare delivery system has to patients, particularly those who are looking to assert their right to define what for them is a completed life. And we're going to be looking at this issue today from both a academic, a clinical, a storytelling perspective, all of which is intended to inform our objective of influencing the standard of care, that is the clinical, moral, and legal standard of care, being what clinicians are expected to do in order to fulfill the needs of their patients and to provide what we consider legally and clinically competent care and treatment. So we're going to start off with a simple question. What is narrative medicine, and what does it have to do with narrative ethics and end-of-life care in the context of a completed life? And I'm going to hand that question off to my friend Danielle. In case you didn't pick up on the connections, Danielle and I have both been teaching at Columbia and at Albert Einstein for many years, and see the relationship between clinical bioethics and narrative medicine as two sides of a coin. So Danielle, what is narrative medicine and what does it have to offer?
Thank you so much, David. And let me just say what a joy it is to be doing this event with you and everybody else who's present, albeit virtually today. This is such an important topic and such an incredible gathering that's already occurred. And David, I completely agree. Your secret plot to bring us together and to bring our fields together is personally gratifying and interesting, but more importantly, is a synergy that makes a lot of sense and that hopefully will be of great benefit to end-of-life care and decision-making and to my field. So let me address your question, because most of you probably have not heard of narrative medicine before, which is completely fine. It's a young field. So let me tell you a little bit about it. Narrative medicine began as a means of practicing medicine as a way of fortifying clinical practice with an attentiveness to narrative. So what do I mean by this? The clinician listening to the patient must be attentive not simply to the data that they have to then put into the fields of the electronic medical record and so forth, but they have to be attentive to the entire narrative that the person in front of them is offering to them. So the form and structure of the account, where does it begin? Where are there silences? Who's doing the talking? Which voices are heard? Which voices are left out? Where does it end? These are all the skills that we bring to bear when we talk about literature or other forms of narrative in creative spaces. And the central idea here is that in doing so, the clinician comes to better understand the lived experience of the person who they're called to care for. And this does not mean, this is not some halcyon vision that the clinician has 3 hours to just sit and listen endlessly. This is a real world intervention to say that these are the narrative skills that can be practiced within any context, and that will improve the quality of care and the affiliation between clinician and patient. And I would like to draw your attention to one of the key texts in the field, which is my colleague and mentor, Rita Sharon, whose book, Narrative Medicine, Honoring the Stories of Illness. She named the field, and she pulled together a group of interdisciplinary colleagues who really set forth the founding principles and practice of the field. And they included such figures as philosopher Craig Irvine and literary and film scholar Morris Spiegel and clinical ethicists and creative writers. And it's a very interdisciplinary field, but that is the fundamental orientation.
And let me interject that though neither
Yes.
Danielle or I have any financial conflicts of interest to disclose to the audience, you are entitled to know that Rita and Nancy Dubler have been enormous influences in both of our professional lives. Rita having been my teacher when I was studying bioethics 26 years ago, when narrative medicine was literally born. And so that is very much the frame through which we view narrative medicine and the practice of bioethics from the perspective of our training at Columbia and Einstein 20 odd years ago.
Yes, absolutely. There are many different connections here, and we see this as an elaboration of this founding, and hopefully, moving us all toward a place where we can deploy these tools to put them to good use. And let me just add to this definition of the field that the field has continued to evolve, and this figure of the clinician as the attentive reader or listener or translator of the stories that they're receiving is still very central, but it's more expansive than that now, and this is very relevant to the discussion we're having today, which is that the role of the skilled reader and listener and translator is a role that we must all occupy. So if, for example, I'm an individual who would like to have some determination in my own end-of-life narrative, then this question, so that once we frame things in a narrative form, then this goes right into what David's going to talk more about, which is narrative ethics, which is once we understand this, our experiences in the frame of the narrative, it then leads us to ask immediately these questions of, well, who's telling the story? Again, which voices are heard? Who determines when the story is over? Who determines what's going to happen, right? And so this is a development of the field of narrative medicine that is very much in keeping with this emphasis.
So, Danielle, what is it you're trying to teach your students? And who are your students? Who is studying narrative medicine in the master's program at Columbia and in the narrative medicine courses at Einstein? What are they, who are they, and what are they trying to get out of this?
Good question. So Columbia is the flagship program for narrative medicine. It was invented at Columbia and elaborated there, has been for a number of years now, although there are programs elsewhere, and we are very happy about that and do our best to support them. For one thing, there has been a narrative medicine component at the medical school at Columbia for many years now, and it's a required part of students' course of study. So they have to take an elective. It could be in any number of things. They can choose between philosophy of death or poetry writing or dance. It's quite expansive understanding of what forms that could take. And in addition, well, there are a great many initiatives that are underway, including really important initiatives in interprofessional education, trying to get clinicians in training in medicine, nursing, dental health, public health, all to be able to speak to one another better. In addition to that, we have a master's program. I'm the academic director of the master's program. And in this program, to answer your question, we have a wide variety of people. Some of them are mid-career clinicians. Some of them are working writers or social workers, people with an interest in healthcare and narrative. We also have a group every year of usually younger students who are maybe recently out of undergrad or just out of undergrad, and they're heading off to health professions school, mostly medical school, but all kinds of health profession schools. And they have some sense that they know they're entering the medical vortex. They know they're going into this very powerful system of medical training, and they want to get inoculated with a good bolus of humanism before they start that journey. And so they come to us, they study very intensely. You can do the program in roughly 1 year. They take courses in literature and philosophy, in creative writing, illness and disability narratives, and then they head off, and many of them do become clinicians. And then they try to bring this work, the narrative medicine training that they've had, into their clinical practice in many different ways.
And so let me ask you the aspirational question, Danielle. What is your goal? What is it that you will consider the major accomplishment of narrative medicine as a discipline in influencing the humanism and the humanity of the practice of medicine, specifically on the difficult issues that we face in bioethics around end-of-life care and patient autonomy and controlling the circumstances of one's treatment and one's completed life?
Yes. Well, of course, the goal is always to improve the standard of care. We'll talk about that later, and the quality of care. And let me add a very important caveat here, which is that this is not the orientation of the field writ large, and for me personally, is not at all opposed to biomedical knowledge and the advancement of biomedical treatment and diagnosis. And I mean, some have different perspectives on, are not aligned with allopathic care and so forth. But this is more of an intervention that aims to try to humanize clinical education. It starts pretty far upstream, and then also aims to look at structural issues in place that reinforce inequalities. And what do I mean by that? That can be inequalities in terms of racial disparities, social disparities, socioeconomic disparities, and also the inequalities that take place in the clinical space, in which people who are in the role of a patient or the role of a family member aren't able to have the kind of narrative authority that they should. And in my view, for this to really happen, it requires a structural change. So, for example, if you think about healthcare education as a place upstream, I mean, eventually where it really matters is when it actually, is affecting people's lives when they're receiving care or engaged in care. I think that in the educational space, we have to see an acknowledgement, an opening of that space to many different voices, not just as, okay, here's a medical school classroom, and now we're going to have a guest lecturer come in and say, what is it like to live with diabetes? I'm not opposed to that. That's great. But that's still, we have to be in this silo, and this is a protected space, and the patient voice is relegated, is in this particular box, just as it is in the medical chart. Can we imagine, and can we work toward a truly collaborative and expansive space in which the voice of the patient has primacy, at the same time that we understand that obviously clinicians have medical expertise, and that has a certain kind of primacy as well, but that they coexist and that the different forms of knowledge are respected throughout.
So
it's a very grand vision of change. Go ahead.
There you go. So let's bring that down to more concrete terms. Let's do a quick role play. I'm a doctor. I know that's a stretch, but I'm a doctor, and you bump into me at a restaurant or at a cocktail party. We used to go to cocktail parties, not so much anymore. And you want to make your pitch. You want to say, you doctors, you could learn something from narrative medicine. What's your pitch? What's your value proposition?
Well, value proposition, that's a very corporate kind of term. It's like I'm selling something. Ultimately, it's an ethical pitch. But that's actually a very tricky question, because you have to come at it kind of obliquely. Because I think that clinicians are trained with, in a very powerful field, with a powerful set of tools that they learn, an incredible body of knowledge that they make huge sacrifices to acquire and to undergo the training. And so the problem, I think, when we're trying to ask the question, well, how could we do this differently, is you often run into, in my view, a kind of a knee-jerk reflexive defensiveness, which is to say, oh, are you saying that, that the passenger should fly the plane, or the patient knows better than I do about how to do their hip replacement or whatever? And we have to be able to have a conversation, and I'm very aware I'm saying this in the political climate that we're in, not sorry to invoke that, but we have to be able to have a conversation where we're not falling to one side or the other of that divide, and that's very challenging.
Absolutely.
Yeah.
I would like to see, from a clinical ethics perspective, I would like to see more information recorded in a patient's medical record, whether that's a paper record, there are still a few of those floating around, or an electronic medical record. It would be valuable for me, and we'll talk about this more a little bit later, to get a richer version of the patient's story, the story of their treatment, whatever their disease state is or whatever their medical need is, whether it's curative or preventative or palliative. And I'd like to be able to tie that to some information about what that patient's lived experience was before they entered the healthcare delivery system. So are you able to help clinicians internalize that responsibility in narrative medicine?
I hope so. I mean, that's the goal. I agree that those kind of structural changes are really necessary. And again, if you figure, I'm just going to keep banging this drum, if you figure the medical chart as a narrative, then doesn't it, we're all just so used to this because this is the way that it is. And we're really, if we're not clinicians, we're really disempowered in the clinical encounter. But isn't it strange that a narrative about a particular individual doesn't contain the voice of that individual unless it's mediated by the clinician, patient reports, whatever. And so I do think, I mean, why not? We could have a way in which the individual who's in the role of the patient, who's there for care, has a way to note their own narrative, their own experience. It sounds radical, but it really shouldn't be.
When you say it out loud, it makes such sense and doesn't sound radical anymore. And I can tell you from a clinical perspective, when I'm called in to consult on a patient or with a patient who is involved in hospice care, which I do for the visiting nurse service, we're always looking for more information and a better understanding of the patient's story. And what attracted me to narrative medicine from the get-go is it creates a language, it creates a mechanism for getting that information into the medical record, which you can only accomplish if you get the clinician to understand that that's valuable, hence the phrase value proposition, and get the patient to understand that they will benefit from sharing with their clinicians the story of their lives. And so stories are as important now as they've ever been in medicine, perhaps more so because the healthcare system is so disjointed.
Absolutely. Yes, and this is the kind of thing that has to happen on a structural level, because you simply can't. There are legal reasons. There are all these barriers in place to try to do this on an individual level. And that's not to say that there aren't many clinicians and people who work in end-of-life care whose orientation is toward the primacy of the lived experience of the individual who's receiving care. This is not what this is at all. It's like, how do the structures support that orientation? But before we get too much further, I've talked a little bit about narrative medicine, and we'll continue to talk about it, obviously. But David, could you tell us a bit about narrative ethics?
Absolutely. And this is literally the other side of the coin, because if narrative medicine is the incorporation of the patient's voice and the patient's story into their care, narrative ethics is the frankly not remarkable proposition that a patient's life story should be internally coherent, that there should be a narrative thread from the earliest days of a patient's life through the plan and the execution of the end of a patient's life, whether that is in response to disease or on the basis of a decision to refuse treatment. So the narrative ethic is this notion that patients' stories matter, and especially for patients who are not able to share information anymore because they are suffering from the effects or side effects of a disease process, or they are suffering from some debilitation such as a stroke that leaves them unable to communicate effectively. We need to have somewhere to look to find out who is this person, not just what does their advance directive say or who did they appoint to be their healthcare agent, but what was their life like? What should we draw from their lived experience to inform the recommendations that we make about continuing care or transitioning to palliative care or hospice, and how to interact with a surrogate? Right? A surrogate is the legally designated individual who has the authority to make decisions. Having the authority to make a decision on behalf of a loved one or a friend doesn't translate into knowing what the right decision is. And narrative ethics is a really valuable tool that we use in clinical ethics consultation to understand how the decisions that are made by the clinicians, by the surrogate, ought to connect to that patient's lived experience so that the way their life ends makes sense in the context of the way that their life was lived. It doesn't work unless we have those raw materials, right? Narrative medicine, from my perspective, both as a healthcare lawyer who deals with responsibility and professional ethical obligations of clinicians, and as a clinical ethicist who's trying to help patients who maybe aren't communicating as well as they used to, and helping surrogates to make decisions about what makes sense for that patient, even if it's not reflected in their advance directive. So we're really trying to use narrative, use storytelling, story listening as a way of understanding not what can be done for a patient legally or clinically, but what should be done for a patient on the basis of what their values and preferences are, the best way to receive that information is from the patient's own voice. So my aspiration is for there to be a little section of the electronic medical record, sort of a little box in the upper right-hand corner that says, Sally is a blank, lived her life, had these experiences, loved people who were lost, who had this experience in a narrative form. But unfortunately, clinicians aren't, frankly, for the most part, up to the task. And I'm counting on you and your discipline to get them up to that task. You know, it's funny, years ago, the federal government, in response to lots of community pressure and changes in the way society operated, passed a law, the Patient Self-Determination Act. Sounded very grand and really ambitious, but really all it was a little green sticker. And it went in the upper right-hand corner of the face page, which was literally the face piece of paper in the medical record. And it had a box. It had a checkoff for advance directive yes or advance directive no. That, unfortunately, is the crude kind of tool that the law is in settings when we are trying to improve the quality of care, the ability of patients to influence their care. Radical 20 years ago was adding to the history and physical form, somewhere after personal history and before social history, a simple question. I actually did this at one of my hospitals. I had, and it was a fight, because getting anything added to a form in medicine is a power struggle and an ideological struggle. And I said, you know, could we just add the question, who do you want us to speak to about your care if you're not able to speak for yourself? A simple question, not one that says, who do you want making life or death decisions for you, or who do you want deciding whether care should be withheld or withdrawn? Just who do you want us to talk to? And then a follow-on question. So I actually stole 3 lines of narrative, 3 lines of text in what was then a paper document, one for who do you want us to talk to if you can't communicate yourself? Do you want that person to be your healthcare proxy? And of course, what is the person's name and how can we get a hold of them? That's a tiny step toward inviting those voices, inviting those stories into the process. I have to confess, it didn't go well. We went back years later and looked at the completion rate. It was pretty poor. And even when the patient checked off, yes, I would like that person who I identified to be my healthcare agent, that person was not able to accomplish becoming a healthcare proxy in far, far too many cases. So if you were able to wave the proverbial magic wand and create that space now in the electronic medical record, what do you want to find there? What do you want clinicians to both solicit on the history side and receive and absorb and internalize on the reader of the story side? What should we be striving for?
Well, I think that those kinds of questions are necessary. And, you know, ultimately the basic structure in which there, you know, questions that are being asked and information that's being elicited is not going to change dramatically, because this is information that is needed to provide care. I mean, I don't dispute that by any means, but like even in that, I mean, and I understand that even that was impossible to achieve in that context. I mean, it's such an uphill battle, but even if we achieve that, I think that is a huge step forward if we can do that in a meaningful way. And there has been progress in terms of eliciting information about people's values and their wishes. Certainly, I mean, this is, you know, what this field is devoted to. But in that structure, it's still a piece of information that's being elicited and framed. It reminds me that the program that you and I both teach in the Einstein Bioethics Master's Program, where we have a lot of mid-career clinicians, really wonderful to have these discussions with them and with everybody else in the room. We talk about the principles of bioethics, foremost among which is respect for autonomy, respect for patient autonomy, and everybody nods and everybody agrees. And then inevitably there's something comes up and the clinician will say, yeah, no, I think it's really important that we allow the patient to make their decision. And I'm always caught by that, because the framing is still, if you have to be allowed to determine, then that's not autonomy. And one game that I like to play, it's actually a very serious game, is to flip that rhetoric. And to imagine if it were habitual for us to say, well, we have to allow that clinician to determine the proper course of care. We would never say that, because clinicians have a tremendous amount of authority. And so the idea of, we don't have a principle of respect for clinician autonomy because it's normalized, it's routinized. I mean, I'm sure, clinicians would demonstrate, well, actually, but my ability to provide care for my patients in the way that I wish is being abrogated by hospital administration and insurance and non-compliant patients. That's a whole other thing, and so forth. But that is in the context of an enormous amount of legal authority and institutional authority, and it's inscribed in language and in the structure of these narratives. And this goes, so to bring it back to your question, the very narrative structure of a case report, which fields are there, who's doing the asking, who's doing the answering, is already framing it in that way. And I just want to read a brief passage from Rita Sharon's narrative medicine. So, and just maybe if we didn't mention it before, she's an internist. She's a physician. Right. And
if you don't know narrative medicine, if you don't know Rita Sharon, you don't know narrative medicine. And she started her career as a practicing physician, and it was in the early 90s that she got her PhD in English, which was her academic and intellectual foundation for this discipline.
Yes, and that arose, as she tells it, that arose out of her clinical practice, that here she was trying to treat her patients. She began to realize that the complexity of their lives was something that she needed more narrative acumen in order to provide good care, which is not to say that every clinician has to get a PhD in English, but she did, and we're all the better for it. But anyway, in her book, she tells the story of a new patient in her internal medicine practice and the ways in which she employed narrative medicine techniques to improve clinical care. So I'm going to quote just a brief passage. A 46-year-old Dominican man visits me for the first time, having been assigned to my patient panel by his Medicaid managed care plan. He has been suffering from shortness of breath and chest pain, and he fears for his heart. They say to him at the start of our first visit, "I will be your doctor. And so I have to learn a great deal about your body and your health and your life. Please tell me what you think I should know about your situation." And then I do my best to not say a word, to not write in his medical chart, but to absorb all that he emits about himself, about his health concerns, his family, his work, his fears, and his hopes. I listen not only for the content of his narrative, but also for its form, its temporal course, that's the time aspect, its images, its associated subplots, its silences, where he chooses to begin in telling of himself, how he sequences symptoms with other life events. After a few minutes, the patient stops talking and begins to weep. I ask him why he cries. He says, "No one ever let me do this before." Now, it's very moving. And, and then if we had, if clinicians in the room always say, "Well, that's very nice, but I don't have 3 hours to spend with every patient." This isn't happening after 3 hours. It doesn't take very much time to know. Actually, you know kind of instantly if the person that you're offering an account to, especially an account of suffering, is truly present to you and is actually receptive to hearing your story on your terms. And
right.
So it's that kind of open-endedness. I mean, think about the way that she framed it. She didn't say, what's your chief complaint? I mean, obviously she wanted to know what his chief complaint was. She needed to know all that ultimately, but she framed it in a way to say, offer me your narrative, and I'm going to try to absorb it and have humility toward it and respectfulness towards it. And with that, then she goes on to explain that in that process, then that results in greater affiliation between clinician and patient and better care.
And we're going to talk about that argument that, oh, I don't have time for this, I have to take care of the patient, in a little while. But you used a phrase, it's one of my favorite phrases in medicine, which is to say one of my least favorite phrases in medicine, the non-compliant patient. It's right up there with the patient who is described often in medical records as a poor historian. So what does the phrase non-compliant patient conjure up for you as a scholar of narrative?
Well, I'll quote Arthur Kleinman in Fadiman's The Spirit Catches You, who said that the term non-compliant, quote, implies moral hegemony. You don't want a command from a general, you want a colloquy. And I think he puts it very well. The premise of that phrase is that there is a proper way to do this, a proper way for the medical treatment to proceed, and that any deviation from that is a matter of poor behavior on the part of the person who's in the role of the patient. Even terms like refuses care, is still the premise of that is that there's a plan of care and this individual is refusing it, right? Well, again, let's play this game of flipping the semantics, right? What if we were to say, well, the clinician was non-compliant with my stated preferences in terms of the way that I want to live out my life. The clinician refused to X, Y, right?
Provide me the treatment that I want, which
right.
may be, as a matter of legal authority and as a matter of professional judgment, the clinician's prerogative. Clinicians don't have to, both legally and ethically, provide care that they think is inappropriate. But if a clinician provides a patient with a choice of 3 options and thinks option number 2 is the best, and the patient chooses option number 1, and the clinician decides, well, the patient didn't choose the suggestion I thought was best, there must be something wrong here. And the what is perceived as wrong is the crux of our dilemma, because there are enormous, enormous organizational challenges to both enabling patients to offer their voice, to offer their stories, and enabling clinicians to accept the patient's authority and accept the patient's decisions, even if the patient maybe doesn't have the decisional capability to make all of the decisions involved. We all learned from Nancy Dubler many years ago that decisional capacity is always decision specific. And I feel like we're not doing a good job training clinicians to accept the fact that a patient can make some decisions and can't make others, and nonetheless that they ought to be heard. That's the organizational challenge that we need to overcome, and that will be our discussion in a few minutes about changing the standard of care. Again, changing the standard of care as a medical question, as a ethical question, and most importantly, as a practical matter, as a legal question, because the standard of care is what defines what clinicians feel they are obligated to do or not do. So I think this has been really helpful, and I hope our audience thinks so as well, in understanding the place of narrative, the place of storytelling in the improvement of the ethical performance of clinicians and the healthcare delivery system as a whole. So I'm going to invite all of you in the audience, if you feel like you want to take a crack at this, to share your medical narrative, to share your medical stories. We've created a place on the Completed Life Initiative website. That's completedlife.org. And if you click on the testimonial section, it's a place where we want to start collecting clinical narratives, the stories of people's experience with healthcare and with the ethics of consenting to or refusing treatment, and how those decisions are guided by the person's earlier life experience. I think we have to take a break. Is that right, Sarah? No, I guess not.
Hi, David. I was on mute. Back. We are good to go, so please carry on.
Okay, and you'll let me know when we have to do the participation code for those of our participants who will be seeking continuing legal education credit for today's event. So,
absolutely. Just one quick note. Sorry to interrupt, David.
Yep.
The participation codes have already been posted in the chat, so the audience has them.
Excellent. If my eyesight was better, I would have been able to see that. So let's get back to this notion of sharing your narratives, sharing your story, and the notion of a patient having the space, the ability to do that within the way healthcare is delivered. It really is kind of the notion of that box in the upper right-hand corner of the electronic medical record that's more than just the sticker, advance directive, yes or no, but is really the place where clinicians can place a narrative, place a story derived from the patient. And the question is, should that be the clinician's obligation? Do we think that soliciting and recording narrative is part of what a clinician, whether it's a doctor or a therapist, part of what their job ought to be? What's your view on that, Danielle?
Well, I think it already is. It's just a question of in what form. But I would ask, to go back to the earlier point, why we can't have a structure in which, let's say it's a parallel chart, and actually Rita used the term parallel chart to describe an exercise that she would do with medical students, in which she would have them write a parallel chart, which was to say not this following a strictly medical form, but to have a more open form in which they could write their own understanding of the patient narrative and their responses and so forth, which I think was very productive as an exercise, as far as I know about it. But if we think, what if the parallel chart were one in which, imagine if you had a piece of paper, if we were still using paper ever, and it were divided down the center, and then on one side of it you had traditional, case report and all this information and so forth, and then on the other side of it, the person who is in the role of the patient has direct access, and they can. We've all experienced this, that if there's something in your chart that's not accurate, or you don't have direct access to it. I mean, I'm not to say that then the clinical chart is something that the patient could directly edit necessarily, or sort of why can't they write their own story?
Well, so interesting you should say that, because there is in fact a legal right of patients to contribute to annotate and to correct entries in a medical record. It is in fact a little known part of the HIPAA privacy rule, and it is grossly underexploited, right? And mainly because it's considered, and I'm interested to hear what you think about this, it's considered an intrusion. We have had in a great many situations, patients, especially during COVID, showing up at the hospital saying, I want to know what my test result is. And in fact, I had this conversation with a physician just the other day. The response was, well, you need to get your test result from your clinician because she or he needs to interpret it and explain it and put it in its proper context, all of which is well and good as part of the standard of care for ensuring that the patient doesn't receive misinformation or incomplete information, but it ignores both the practical, the ethical, and the legal right that the patient has to influence that narrative, that story in their medical record. And it's because physicians and other clinicians often still feel as if that's an intrusion. In fact, the reason we have the law in the privacy regulation that says patients have this right is because patients weren't afforded that prerogative without a legal enforcement. So it is exactly the fact that that law exists and is largely unknown and largely unutilized that is the justification for what you and I are asserting and espousing today, and in fact is the reason why all that we have been talking about the value of narrative medicine and the value of narrative ethics needs to be incorporated into the standard of care so that all clinicians feel as if they have to do it, or else they're doing something that we name, and we name it medical malpractice. So
yeah.
We've got to do that work, and you're going to be part of that work, right? Because you're giving them the ability. As a lawyer, I will give them the sense of obligation.
Right. So we're going to go at it from different angles. You're going to give them the sense of obligation and the legal repercussions, and I'm currently working a little farther upstream, which is to inculcate the future clinicians with a set and patients. Everybody's going to engage in the healthcare system with an ethical duty to maximize the inclusiveness of this process and to think creatively about activism. How can we affect change? It's very difficult. It's not one answer. If it were that easy, it would, we would be in a different place. And to create more and more people who are dedicated to this and who are asking questions, when there's a revision of the EMR or the way that a clinic is practicing, to say, well, why couldn't we do it this way or whatnot, instead of encountering and hopefully not encountering the same degree of, well, because that's the way it's done, or are you saying that the passenger is going to fly the plane, or all this kind of stuff, and trying to shift the conversation.
That is our challenge, and the way we will accomplish what needs to be accomplished in order to both empower patients, and the notion that we need to empower patients, of course, implies that that power lies somewhere else, and so often it does. We know that, and at the same time, put a little bit of fear in the minds of clinicians, not that they're going to provide a treatment for which they don't have legal consent, but that they've failed in meeting the standard of care in another much more fundamental way, and that is in including the patient's voice, the patient's values, preferences, priorities in the treatment plan. Because otherwise you're not providing care, you're just providing procedures. So I've always been, go ahead.
I was just going to say, and I think, look, obviously I wish that we didn't have to resort to fear as the motivator, but just to point out to folk, maybe there are people who are in attendance here today who are clinicians who are grumbling. I mean, the notion that they should be asked to fear repercussions here. We all have to remember that it's really very, very, very difficult to advocate for oneself when one is in the role of a patient. And I keep saying this because I just don't like that phrasing, because I just don't like the kind of flattening of the patient. But I mean, I understand that that's the usage, but also to emphasize that we all occupy that role at one time or another. And in that role, though, it's okay, here I'm in this field, I have a PhD in medical humanities. I do all this kind of stuff. And yet even, if I'm in a situation where, let's say I want to get copies of my medical records for myself, there's one thing to say that what is the legal standard, and the other is what's the conversation that I have standing at the desk with the person who's saying to me, okay, so what doctor are we faxing these to? And I'm saying, no, I actually know that I have a legal right to have them. I'd like to have them. And then okay, so maybe I get them, but I get asked 10 times why, and then I have to pay for it. Whereas if it was for a clinician, another doctor, they would just do it for free as a courtesy, obviously. I mean, all these kinds of things are barriers. And we have to think about that when we are looking at end-of-life care, to say, well, okay, we might have a legal standard, in a given state. Obviously, it varies so much as to what an individual or a family can do. But then what's the lived experience of that? How difficult does it become? And these barriers exist alongside the legal parameters, or not just barriers. I shouldn't put it that way in terms of barriers, but the logistical landscape. And sometimes things are barriers, and sometimes things are facilitators, right? But whatever the access to these rights is crucially important.
Right. HIPAA's been with us for decades now. It hasn't penetrated the standard of care clinically to the point where clinicians feel like, yeah, this is the patient's medical record. We use the phrase, the patient's medical record, but the healthcare delivery system very much guards it and keeps it close to the chest, because sharing control, sharing responsibility, sharing influence, that can be scary. And frankly, the notion that a patient can tell a doctor, this is what I want you to understand, but the doctor has no particular obligation to record or internalize or act on that information, that's a problem, and that's a problem that can only be addressed by a change in the standard of care. And to your comment about fear before, fear has its place. It ought not to be overplayed, but the flip side of fear is the leveling of the playing field, right? Because when something becomes a change to the standard of care so that everyone has to do it, the comment that you paraphrased earlier of the doctor saying, well, I don't have 3 hours to see this patient and listen to their story. I've got to see, 12 patients today, or I can't pay my rent, or I can't pay my malpractice insurance. A standard of care improvement will level that playing field and enable every clinician to feel empowered to take that time and to engage in that process, with the awareness that a failure to do so means that they're providing deficient treatment. And we have known for decades, many decades, long before I got involved in the healthcare delivery system or bioethics, that patients don't get all of the information they ought to, and sometimes don't know what they've been diagnosed with, sometimes for years or even decades. And so I was quite amused when, in our preparation for today's lecture, you said, oh yeah, I just wrote a book about this. So talk for a couple of minutes about metanosis, which is both the term that you coined and the title of the book, and how that relates to patients' experience of finding out under any number of circumstances, oh, you've had this or that condition or diagnosis for most of your life and you just didn't know it.
Yes, thank you for asking. I have a book coming out. Now it's pushed back till November, but it'll be out soon with Oxford University Press. And the title is Metanosis, spelled METAGNOSIS. So it's like diagnosis, but metanosis. And we can have extensive debates on whether the G should be soft or hard. But the reason why you've never heard of it before is because I coined the term. It's a neologism. And the full title is Metanosis, Revelatory Narratives of Health and Identity. And it's available for pre-order. And I'll put a link to my website that has information about it. It'll feed out into the messages in a few minutes.
That's danielspencer.com, right?
Yes, /metanosis.
There you go.
Here, I'm going to type it in and it'll get to you in a minute. So what it refers to is the phenomenon of learning that you have some kind of condition that you never knew about. It's your condition, but you never knew about it. So this can happen either because it was simply never diagnosed, So let's say you learn in adulthood that you're colorblind, and you didn't know about it before. And so from one moment to the next, you realize that the way that you perceive the world is very different in terms of colors, is very different from the way that many other people perceive the world. The other way that this can happen is when the diagnostic boundaries themselves have changed. So I worked with the musician David Byrne for many years, a former Talking Head, David Byrne. I was his art director. And he informally self-diagnosed in the early 2000s when people began to talk about this with Asperger's syndrome. And the point being that Asperger's syndrome didn't exist when he was a child. It came into the DSM in the early 2000s, and then it actually exited again, not that many years later, and was enveloped into autism spectrum disorders. So the experience is one of learning from one moment to the next that you have something that can be considered a medical condition and you weren't aware of it before. And what interests me in this is that it has a potential to really shift the narrative of your experience. So you've had a certain lived experience of yourself, in one way, and then you get this knowledge. And my hope in examining this is to empower people to understand that with this experience and beyond, when you receive this knowledge, whether it's a belated diagnosis or whether relatedly it would also apply to something like genomic information. Let's say you find out that your father is not your biological parent. You receive this, and instead of receiving it like, oh, well, this is biomedical knowledge, this is the authority, I have to be governed by this, this is now the truth. Instead, to receive it and say, okay, well, I can situate this knowledge in the context of my lived experience, and I can decide what its meaning and importance is. And not everybody has that privilege, right? But in some cases, we can do that. And people respond to these revelations in many, many different ways, right? Some people are really happy to learn about it. It provides them with some insight that they didn't have before. Maybe they felt really ashamed and guilty because they couldn't pay attention in school. And now they're liberated because they realize, oh, I have ADHD. So thank you for asking about that.
So I think metanosis is a wonderful example of the responsibility for gently and compassionately sharing information, and that process of a clinician telling a patient later in their life, oh, you may not realize it, but you've been seeing the world, or you've been hearing the world very differently than the vast majority of people, that act is changing profoundly the story of that patient's life and the way they experience their own life story. In fact, the way they conceive or conceptualize themselves as individuals. And that also needs to be part of the narrative medicine process in incorporating that information and the effect of that insight, that realization on the patient's future course of treatment. And from an ethical perspective, the impact of that narrative on how the patient conceives of how they want to live the rest of their lives. And in the case of an extreme diagnosis, how they want to complete their lives. Right. So this is all part of a whole in the need for the standard of care to change, which begs the question, which we should turn to next: how do you change the standard of care? What does it mean? So you've got all those wonderful books on your bookshelf behind you, and I can guarantee to our audience that none of them contains the standard of care for anything, because it is a legal certainty and an ethical polemic that the standard of care isn't written down anywhere. The standard of care exists in the behavior, habits, and priorities of clinicians in a particular discipline who choose to incorporate or reject diagnostic, therapeutic, or supportive interventions for a particular patient based on what the clinician determines, hopefully in consultation with the patient, are the patient's actual needs. And we've seen many examples of the standard of care changing. some of them rather dramatic and even shocking. So there was a time when bloodletting was considered the standard of care. And then modern medicine came in and said, oh, bloodletting, that's barbaric. Toss that out of the standard of care. No self-respecting clinician would engage in bloodletting. Until, guess what? Bloodletting, we now call it chelation, is the standard of care treatment for lead poisoning. Same thing for leeches, right? Leeches used to be a way that you would suck the evil or the disease out of a patient. That was thrown on the scrap heap of medicine until it was brought back. It's a fascinating story. As the best treatment for certain kinds of peripheral vascular disease. So we know that the standard of care can change. And there are even more recent examples of the standard of care changing for the better that are specifically responsive to the point you made a few minutes ago about the doctor saying, oh, yeah, narrative medicine, narrative ethics, that's nice, but I don't have time for that. I need to take care of my patient. And implicit in that statement is the notion that taking care of your patient is something apart from listening to your patient.
Yes, and the thing is that there have been clarion calls of clinicians and among others making this point for many, many, many years about what do we mean by care. And in 1926, Frances Peabody told the graduating class at Harvard Medical School that, quote, one of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. Now, it's a tautology, but it's very, it's very moving too. And because I think it was so clever here is the secret of the care is in caring. He turned a noun into a verb, right? Because maybe we think about it slightly differently when we think about caring as an act and as an ethical responsibility that we all have toward one another. And so what is encompassed within the scope of care? Right. One of the things that our colleague, Lauren Flicker at the Einstein program always reminds us in the classroom is that we should never use the phrase when it comes to end of life choices that we would ever withdraw care. Right. There might be a decision to take an individual off a ventilator or to stop a certain medical intervention, but we would never, ever, ever countenance the withdrawal of care because care is understood to be something that can be offered in many, many different forms. But I just want to take it back. Yeah, go ahead. Go ahead.
It's a critically important homonym problem. And the fact that that word has taken on those two related but different meanings is itself a powerful warning.
Yes, absolutely. Yeah, so, but I want to take it back to this this issue of the standard of care that you're bringing us to. And I'm really curious to hear, have we seen this movie before? I mean, what can we learn about modifying the standard of care by looking at earlier efforts to incorporate, for example, interpretation services as a clinician responsibility?
It was that experience back in the early aughts, 2001, 2002, that really crystallized my understanding of the importance of changing the standard of care as a means of improving the quality of ethical decision-making in medicine. So it's a funny story, and let me share it. I think we have a few minutes. Yeah. I was at a client hospital of mine in Brooklyn for some inane meeting, and somebody comes bursting into the boardroom and says, there are people setting up a picket line in front of the hospital. What should we do? And, I'm the lawyer. I didn't feel like it was my place to answer the question, but nobody else was saying anything. So I said to the security guard, I said, well, invite them in. Both an ethical decision and a pragmatic decision. It's never good for any hospital to have a protest going on in front of the hospital, especially when you don't know what they're protesting about. So we invited this group of, 30 or 40 people into the hospital, something we could never do during COVID, but these were simpler times, and gave them half an hour to explain why they were protesting, and they were protesting over inadequate interpretation services. By the way, people sometimes use the word translation to describe when one person converts one language into another. Translation as a technical matter is the changing of written documents. So when we talk about interpretation services, we're talking about dialogue, we're talking about spoken words. And they felt as if this hospital was doing a terrible job of providing interpretation services. And somebody asked them, well, why didn't you come talk to us about this instead of just setting up a picket line? And then the answer was really illuminating. They said, well, we tried that at the other hospital miles or so down the road and got us nowhere. So we decided we'd start with the protest and then move to the discussion. Long story short, well, okay, maybe too late for that. That started this wonderful dialogue with this organization. The organization then was known as Make the Road by Walking. Now it's called Make the Road New York, which was a remarkable education for everyone at the hospital, because, of course, if you're not able to communicate with your patient, you're not able to know that you're not effectively communicating with your patient. And so we really took to heart the obligation to provide interpretation services as part of the standard of care. And in fact, in the course materials today, I shared with everyone the settlement agreement that the hospital entered into with the Attorney General and the U.S. Government Office of Civil Rights, agreeing that we would incorporate this into our standard of care. Years past, we had legislation, there was a whole legal process so that interpretation services are now a part of the standard of care. And yet, years after, I would hear in the physician dining room, yeah, they let me into the physician dining room, I would hear this complaint that, well, fine, but we have no time for this. It's taking away from us taking care of the patient. As if you could be actually taking care of the patient if you haven't heard their voice, haven't been able to receive information from them to inform your diagnosis and treatment plan, and more important, haven't been able to convey to the patient what has been done for them or to them. And I have to say, it's quite remarkable what has happened to the standard of care in the ensuing 18 years, which gives me hope that we can do better. That this notion of taking it from just understanding what words the patient is speaking to actually understanding what the patient's needs are and how proposed treatment fits into the story of that patient's life, that would be wonderful. And it's clearly something that we need to work toward.
Well, I really appreciate hearing about this, because it can be so dispiriting to think about all the work that lies ahead. And yet, when we take stock of something like this, which is clearly, an enormous advancement and improvement, we realize that then it becomes something that hopefully becomes a norm, and to which people coming upon the scene would say, well, how could we not do this? And this is a point that our mutual colleague, Tia Powell, Dr. Tia Powell, who's a clinical bioethicist and psychiatrist, she and I often co-teach Anne Fadiman's The Spirit Catches You and You Fall Down, which is a wonderful nonfiction account of a tragic story of miscommunication and cultural miscommunication in the case of a young girl with epilepsy. But when did the case take place? In the early 90s? I think the book came out in the mid-90s. Anyway, it was at least 20 years ago, probably 25 years ago. And the point that Tia makes when we're teaching it in class is saying, this is something that has fundamentally changed, that when you're in the hospital, whatever the system is, if it's the phone, it's imperfect, yes, but if it's the picking up the phone and being able to get the interpretation services, with hundreds of languages, that this is now the standard of care. And And so anyway, so I really appreciate this example because it gives us a reason to keep doing this work.
Absolutely. And, you know, it's funny that you talk about the standard of care that way, because the standard of care has been changing forever. And after World War II, medicine took giant leaps forward technically. But my students would be horrified if I got through any talk about law, medicine, and ethics without talking about Benjamin Cardozo and the decision in Schlöndorff versus the Society of New York Hospital. But it's quite instructive on this point about changes in the standard of care, because Schlöndorff was a case involving surgery that the patient not only didn't consent to, she explicitly said, "Don't do this. Don't remove my uterus." Or, excuse me, don't remove the fibroid from my uterus. And the doctor went ahead and did it anyway. And Mary Schlöndorff sued. And Benjamin Cardozo, in the decision in that case, penned the now famous phrase, "Every person of adult years and sound mind has the right to control what is done to his body," even though Schlöndorff was a woman. But when Cardozo articulated that standard of patient consent, not informed consent, just simple consent, and patients' rights to determine whether anyone even touches them, even a doctor, that was considered heresy by the medical profession. That was 1914. In fact, that decision in Schlöndorff disappeared from the medical and legal radar for decades before it was resurrected as the intellectual and moral foundation for our modern movement of medical consumerism, which gave rise, frankly, to everything that you and I do every day. Well, this has been quite a chat. It's perhaps sad that it took a national conference and an audience of I don't know how many people for us to have time to actually talk about these issues, but I'm glad we did.
Well, me too. And I think this is just the beginning of a, as they say in Casablanca, of a beautiful friendship. So, you know, no, but seriously, in terms of the synergy between our fields, and just to go back earlier, because I know that most people aren't familiar with these phrases, these terms, you know, narrative medicine or narrative ethics, they're essentially the same thing. It's just that they arose from different places within the landscape. So narrative ethics came up out of bioethics as a way to say, to practice bioethics ethically, we need to have an attentiveness to the lived primacy of people's experience and narrative. And narrative medicine arose in a slightly different place, but their goals are very much aligned. And I hope that that we can all work together to deploy some of these tools to affect positive change when it comes, particularly in end-of-life decision-making.
Yeah, I see it as two sides of the same coin, and just looking at the same set of opportunities and challenges from different perspectives. The other metaphor, of course, is the four blind priests trying to describe an elephant. So let's move to some questions. Before we do, I just want to note that in the reading material for today's session is some information about our latest example of the challenge and need for narrative medicine and narrative ethics, which is the story of Susan Sarin, a woman who moved to an assisted living facility specifically in order to be able to define her completed life, as she suffered from frontotemporal lobe dementia. So you can read about Susan Sarin's story in those materials, and we will be moving to a program on that scenario and on the legal circumstances that she has confronted as a future event for the Completed Life Initiative. All right, and with that, I will turn the helm back over to Sarah. And Sarah, are there any questions for us?
Absolutely. Thank you, Danielle and David, so much. This has been an incredible conversation. So I want to refer back to something that David said, actually, that Nancy had quoting Nancy Dubler, that decisional capacity is decision specific, and how perhaps in Western medicine specifically, kind of this do everything approach is taken to be the standard of care. And so I was wondering, Susan Kirsheimer wrote in a question asking about the extent that clinicians' cultural biases, perhaps conscious or unconscious, impact the interpretation of their patients' narratives, and how bias can be addressed in the training of narrative medicine and the practice of narrative medicine in the clinic. And to Susan's point, you know, in the standard of care, or perhaps not in the standard of care, how can a patient's ability to decline treatment, how can that affect their experience of their care at the end of life?
Danielle, you want to go first? I think you're muted, Danielle.
Yeah, I'm not sure. There's a lot in that question, but I'll just pick up on the question of cultural understanding, right, towards the beginning. This is a really important question, and it's a really tricky one. And I think that there have been a lot of perhaps well-intentioned efforts to increase what's called in clinical circles often cultural competency. But that can become kind of tricky, which is to say, oh, well, you know, people from this particular culture tend to be more stoical and they're, you know, they don't express their pain, or people from this culture, it's a, you know, patriarchal culture. And so the male relatives will be making the decisions. Or it's not to say that these aren't accurate in a given case, but well, I guess that's exactly the phrasing, is that it's in a given case. And so again, I play this game of doing the flip, thinking about who's empowered and who's not empowered in a given situation and reversing the terms. So in this case, the empowered culture is whatever the dominant hegemonic culture is, which in this case, in our country, is somebody who speaks English and is not from another country, even in the way that I'm saying other country, but you know what I mean. And so in that case, would you say that, well, Caucasian people of European descent tend to be X, Y, or Z? No, because we afford more individuality to people who are in that dominant group. And so the cultural competency thing has to have an ethical dimension that, again, puts as the primary responsibility toward the individual and toward the family. In fact, going back, now it's the third time I've cited the Fadiman, but I think that the book is really helpful. The spirit catches you and you fall down. And in fact, there's a very good critique of this notion of cultural competency written by scholar Danielle Taylor, who calls this the billiard ball school of thought. I'm paraphrasing. And she calls it a static, reified, essentialist understanding of culture here. So we have to bring a good deal of humility. My colleague Sayantani Dasgupta coined the term narrative humility to emphasize the spirit that even if we're still in the frame of thinking about the clinician or the clinical ethicist stance toward a person who's in the role of patient, has to have a good deal of humility towards that narrative, and has to begin from an understanding that, no, I'm not going to, I can't master my patient's story, right? I want to engage with it with a good deal of humility. And there are other thinkers in this field who take parallel stances. Kidd and Carell talk about epistemic humility. There are others who talk about cultural humility. So I think obviously the underlying term here is humility. And this goes back to what Dave and I are talking about in terms of what can happen in the field of medicine, and how is it possible to have a sense of humility when it comes to these matters. But David, do you want to pick up on some of the?
Please. So Susan's question brings to mind one of my earliest encounters with an ethical dilemma, and it involved a patient who was refusing a pacemaker. And it was a relatively low-risk procedure. In fact, it was a very low-risk procedure, and it didn't make sense to the clinicians why he would be refusing it. And when I met the patient, it didn't make sense to me. What he was saying was, well, I don't want to make this decision. Let my children make this decision for me. And the initial interactions were all over the phone, so I had no sense of who these people were. And when I finally met the patient at the hospital, I realized he was a 93 or so year old gentleman of African ancestry who grew up in the islands and then in South Carolina. And he had a sense that it would take me 30 years to appreciate. He had a sense of what a completed life was for him. And for him, that was letting go because his children thought it was his time. And to Danielle's point and to your point, Sarah, about decisional capacity being decision specific, this patient didn't lack decisional capacity. He exercised his decisional capacity to delegate responsibility for making this decision about how he would complete his life. And frankly, I didn't get it. It was a long time ago. I was viewing these kinds of requests more through my lawyer's eyes than through my ethicist eyes. And I would interact with Mr. Rowley very differently today than I did in 1992, I think it was. So yeah, this is an important part of our training to understand the stories that people tell us in clinical settings. The other story that comes to mind is one of my favorites, the case, literally a court case, of Mary Northern. And one of Danielle's and my colleagues from Einstein, Abby Notterman, excuse me, sorry, Abby, has done extensive research on how the care providers and the priest and the nurse and the judges all failed to understand Mary Northern's lived experience and her desire not to have treatment for gangrene in her feet. In fact, her choice to not even acknowledge openly that she had gangrene in her feet. So understanding people's lived experiences and how that influences what kind of life they want to live toward the end of their lives, that is at the heart of what narrative medicine and narrative ethics has to offer to improve healthcare delivery.
If I can just jump in, it's Abby Notterman, just so she gets the right shout out.
Yeah. Thank you.
But the case of Mary Northern, I pulled up an article. It's a fascinating case that you should all Google it if you're not familiar with it. Really important in bioethics. But I just pulled up an article about it that we use when we're teaching. And the title of the article is, and this is in the legal context, so David should be happy. Anyway, the title of the article is Decisional Capacity and the Right to Refuse Treatment. And I promised that I would keep banging this drum of attention to semantics. What if we were to say, instead of the right to refuse treatment, the right to choose treatment?
Right.
Or the right to determine treatment.
Make treatment choices. Absolutely.
Right. Any number of different options that we could make.
So thank you both. So that brings up an interesting idea of, if someone has essentially a religious excuse of, for example, a Jehovah's Witness who needs a life-sustaining blood transfusion, but can essentially opt out due to their religious preferences, versus someone who may not, be in that faith group and yet still refuse the life-sustaining blood transfusion. Like, how would you counsel the clinician and care team in that situation?
So first, Sarah, let me press you on the use of the word excuse, to borrow a phrase that I was often subjected to by Jeff Bluestein when we were doing our training years ago, patients don't need an excuse to refuse treatment, although your point is well taken, because the law views religious foundations or religious purposes. Notice I'm not using the word justification, because justification doesn't belong in this conversation. But a religious purpose in refusing treatment is treated by the law differently than non-religious purposes, although in a great many circumstances, and most notably the New York State case of Nicholas versus Fosmere, even a Jehovah's Witness who was refusing a blood transfusion was subjected to treatment over her specific and vigorous objection, because the court felt like her religious convictions had to be subordinated to the interests of the then newborn child. And that's a problem. But it's a bigger problem when we view decisions that are based on religious grounds as being different from decisions based on clinical, ethical, or cultural grounds. And that can cut both ways, right? Sometimes we will give more credence to a decision that is framed as a choice between competing options, where we would not afford a patient who is making an objection to treatment or declining a treatment on religious grounds the same deference. It's this tyranny of rationality that we have to be, to borrow a phrase we've been using a lot today, more than a little bit humble about.
Well, and if I can just bring it back into the narrative frame, I mean, so when it comes to these kinds of cases, of course, the question of capacity is primary, because, I mean, look, and this is something that, again, in the bioethics classroom, we have all of these, palliative care clinicians, and they're very candid that they say, oh yeah, I only call a bioethics consult when the patient is not going along with my wishes for their plan of care. It's really, pulling back the curtain and seeing, that. So a bioethics consult, but then also a site consult to see if the person has capacity to make that decision. This is an integral part of the process. It's part of respect for autonomy, is that they have informed consent and that they have the ability to make that decision. But then the decision, the determination of whether that individual does have that capacity can be understood in narrative terms, because part of it is, well, okay, do they understand, can they repeat back the risks and benefits and all this kind of stuff? Fine. But then it's, if they say, well, I have this religious objection, or I have some other kind of value that conflicts with what the clinicians are proposing. What I mean by it in the narrative frame is that then there's basically determination made by the clinicians, which is this narratively satisfying enough? Is it cohesive? And I have a problem with this, which, to what you were talking about, David, which is that I'm all for giving credence to saying, well, yeah, this is in accordance with the values of this person's faith community. If that's their faith community and that's important, then absolutely. But that's also just a way of saying, well, this is a more coherent narrative, so we're gonna give it more privilege. But what about the person who says, well, these are my values. They don't happen to be to map onto a particular religious text. I don't have a faith leader, but these are my values that I've lived by. They're going to have a much harder time being able to determine the treatment that they want to receive in that case, because it's not going to have the degree of narrative coherence.
And the practical reality is that from a legal perspective, it is easier to accommodate a religious objection to treatment if the clinicians and the institution's lawyers and the judges want to, which to your point is if they agree with that alternate treatment plan, because faith is not reason-based. You can't reason your way to faith, which does not mean that it is unreasonable or irrational. It is just other than reason-based. And so the law and our entire system of adjudicating decisional capacity doesn't have good tools for dealing with that on religious grounds. And so we do treat those classes of patients differently, not for any particularly good reason other than faith lies outside our rationally based system of adjudication.
Thank you so much, both of you. So we had a follow-up question from Kirk Allison about the narrative of the 93-year-old gentleman who grew up in the islands and then Carolinas. So he asks, what vulnerabilities are raised in being embedded in others' narratives, whether others means the family, their community, friends? What are your thoughts?
So the biggest concern I have carried with me since that experience back in the early 90s is the notion that I was imposing upon him my expectations of the value of a long life and the value of the last days, weeks, months, years of one's life especially. And that's a kind of myopia that we need to be very sensitive about. And it speaks to a lack of, and this is another phrase that we're going to turn on our heads now, a lack of professional competence, not competence in the decision-making sense, but in the capability. Are you adequately trained and experienced to do the work that the patient needs? We frame the notion of the qualities of a clinician or the qualities of an ethicist, especially in these situations where we're dealing with end-of-life care, and even more specifically when we're dealing with the notion of a completed life, as opposed to the sort of more narrow and plain vanilla circumstance where someone is refusing a treatment because they have an underlying terminal condition and they're about to die anyway. That's the narrow, simple, plain vanilla circumstance. The circumstance presented by the notion of a completed life and the prerogative of a patient to make those decisions calls upon clinicians, including ethicists, to think much more broadly. And so the qualities we look for in these circumstances, well, there are four of them. We want competence, professional competence. We want confidence. We want clinicians who are able to feel comfortable sharing their professional perspectives and to have them heard in a way that they are convincing. And then we have to pair competence and confidence with humanity and humility, because competence and confidence without humanity and humility is inherently out of balance, right? And what we're shooting for is balance in all things. It's the ancient notion of yin and yang.
Yes, and I would add to that, I think part of the question spoke to the issue of the wishes of the family member, other family members, is potentially, maybe I'm reading into the question a little bit, but this is something that comes up a lot, is potentially coercive. You know, an individual who says, oh, no, it's my time. Well, are they saying that because maybe their family members, they feel that they don't want to be a burden on their family members or an economic burden? And it certainly does raise really important ethical questions. But we can put that in the context that we're always existing in relation to others. I mean, it's not to say that it's not an issue that we need to consider, but if we go back to the principles of bioethics, you know, the fundamental principle of respect for autonomy, there's a strong argument to be made that there's no such thing as individual autonomy that's divorced from others. In fact, there's a whole movement. This is kind of like narrative ethics in relation to bioethics. In relation to the notion of autonomy, there's a kind of a parallel track which calls it relational autonomy. And this comes out of a lot of feminist thinkers in particular who point out that we exist in relation to others. And even even cases, if we try to think of an individual who doesn't exist in relation to others, and here as a narrative medicine scholar, I take the liberty of jumping over into literature and talking about Dostoevsky's Underground Man in Notes from the Underground, who, if you've read it, is a long solipsistic rant, and it's just him talking. It begins, I am a sick man, I am a spiteful man, I am an unattractive man, I believe my liver is diseased, and he goes on. But the thing is, you read it, and literary critic Mikhail Bakhtin made the point that even though there's no interlocutor in the story, and it's just this one person talking, it is profoundly relational. Mm-hmm. We exist in relation to others, even if we're talking to ourselves. That also is a relation, but usually we're making decisions in our lives in relation to others. And I know that I went on a bit of an excursion here, but there's nothing wrong with somebody's life decisions being in that context. It's sort of it's sort of where we start off from. Yeah, go ahead, David.
Yeah, Dostoevsky is specifically describing in his rant, and not that there's anything wrong with rants, his condition in relation to or in comparison to some norm, some community standard that he felt like, he was not measuring up, and he was not happy about that. Interesting to get back to the question that brought us down this meander, and quite a wonderful meander it is. The questioner should know that the patient who was refusing the pacemaker, when he said, talk to my children, I found out what he actually meant was talk to my oldest child, his oldest daughter, who said when I first spoke to her on the phone, it's his time. And I was horrified by that notion, that someone would decide that it is just somebody's time. When I got to know the four of the six children that I wound up meeting a little better, it was more, she was saying, it's our time. And what she was saying to me was, it's our time to be old. We shouldn't have to have this burden literally until our dying day, and then bring in a medical dimension to the consult. The patient was in a whole lot better physical and medical shape, and I would argue spiritual shape, than any of his children, who were suffering from a good many more comorbidities than he was. And yet it was hard for me to accept that he would defer to his children and let them make a decision that it was his time, meaning he would not get this rather simple and life-saving intervention. P.S. He ultimately got his pacemaker.
Great, thank you both. So a follow-up to this element of the community and the family, holding the patient through their experience going through treatment and care. Ashley Sweet asks, if a patient designates a surrogate decision maker in their personal narrative, who is not legally the designated decision maker in the surrogate hierarchy, how would you recommend we proceed in case there are future decisions to be made regarding withholding or withdrawing life-sustaining treatment or conflict among family and friends? Should we encourage advanced directive completion in these cases? And what are the nuances? Your thoughts?
Yes, 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 and yes. Nancy Dubler taught us in days gone by that the decision to appoint a surrogate is the decision that requires the smallest measure or quantum of decisional capacity. And especially before in New York we had the Family Healthcare Decisions Act, my guide rule was, if the patient identifies someone who is real, that is not Casper the Friendly Ghost, and someone who is still alive, that is not their spouse who died 20 years ago, that you should give serious consideration to that appointment of that individual. And I would further caveat the scenario that was described, was it by Ashley?
Yes.
Ashley, though lots of states have adopted forms for designating a surrogate and, for example, hierarchies of surrogates who are not designated, such as under the Family Healthcare Decisions Act, that's only the beginning of the ethical discussion, because we ought not to allow surrogates to make decisions that we know to be inconsistent with the patient's either prior expressed wishes or the values and priorities that they have evidenced in other decision-making in their care, which brings us full circle back to the beginning of this discussion about the importance of the standard of care requiring clinicians to record the reasons for those earlier decisions so that there is a canon to refer to on what is the meaning of this patient's life.
Great, thank you, David. So to that point about having a note in the patient's care record, or EMR, around their personal narrative and story, Jocelyn Winslow asks, is having a patient's narrative included in the medical record influenced in any way by the fee-for-service versus a capitated reimbursement system?
Oh, yes. And this goes to Danielle's point earlier about the clinician who said, well, yeah, this is all fine, but I don't have 3 hours to spend with this patient. The reality is that this is one of the basic lessons of management in any MBA program. Every system is perfectly designed to produce the results it produces. And we have built a healthcare delivery system around a productivity model that prioritizes volume over quality and prioritizes the reimbursement structure over the value structure implied or espoused in a particular model of care. So the notion that we're getting something that we don't want is frankly, irresponsible. We're getting exactly what we want as evidenced by our actions in defining the way healthcare is paid for, starting, I might add, with the notion of employer-defined health insurance programs. And we won't launch into a full discussion of the Hobby Lobby decision and the barriers that have been created for women getting access to birth control. But it is very much a public policy consequence, a direct, rather predictable sequelae of the decision made right after World War II that health insurance could be bought by an employer for an employee with dollars that are not considered income to the employee and therefore not taxable. That tax benefit was created for the specific purpose of getting more people to have health insurance. But they could have just as easily decided that the dollars spent by an employee are not taxable if they are spent by them on a health plan, and still empowered the employer to negotiate collectively on behalf of all of their employees to get a volume discount, to get the benefit of market leverage, buying power in the healthcare delivery system. We decided not to do that. And I think one of the obvious consequences of the Hobby Lobby decision on and in this election that we are now in the middle of will be a rethinking of that incentive for employers to buy health insurance for their employees, where the identity, as a matter of epistemology, the identity of those dollars is a dollar of the employers, not a dollar of the employees. And that's a completely semantic distinction, but it has enormous legal consequence. Because if the tax code provisions were just reframed to say that dollars spent on health insurance for an employee are the employee's dollars, And as with our discussion about whether the patient has the right to care or the clinician has the right to refuse to provide care, if the dollars as a matter of identity are the employee's dollars, and the employee has their own agency, has the right to decide, I will participate in the employer-sponsored plan and buy it with these tax-deferred dollars or tax-exempt dollars, or not, that empowers the patient, the recipient of the health insurance, and the care that it buys without upsetting the incentives that society has decided we ought to impose to have health insurance, which we saw in the Accountable Care Act debate is an enormously important issue for our economy, but also a very divisive issue from a public policy perspective.
Yes, and I think that that's a really important example of how the framing and the structure and something that we become habituated to has just such pervasive effects in terms of how in terms of how the care is experienced and delivered and how we conceptualize it. I mean, I think a lot of people would be surprised to think, to question the notion of employer-sponsored healthcare plans, because that's the norm in our society. Well, it's not the norm everywhere, and David has just outlined, some of the key consequences of it. If to go back to this question of care, if our founding question is, well, how can we provide effective care? This is not the system we would wind up with by any means, and care would be something that we would understand to be grounded in the individual, in the kind of care that individual wants to receive. Not to say that there would be no limits on it. I mean, there's a finite number of resources, and we're all facing mortality eventually. That said, within that, how would we conceive of it? And we're just so far away from that. I mean, the notion that, and this goes to, having sympathy for clinicians who really do want to provide care in the best possible sense to their patients, but their reimbursement, which is to say their compensation for sitting and having a discussion about end-of-life values and decision-making it's not worth it to them. But the system doesn't. I'm not saying that there's nothing there. I mean, it's something that can be done in the course of a clinician encounter and all this kind of stuff, but it's not incentivized. I mean, so there's some efforts at reform. We have the medical home. There are some practices in which, some systems in which it's not fee-for-service, and the idea is that you have a collaborative team with the goal of providing cohesive care that's truly patient-centered. But I would and going back to the semantics, I would suggest that the need to coin a term for patient-centered care is completely absurd, and it speaks to the fact that our system is not patient-centered, right? I mean, and again, just to continue the rant, it's the same thing. Like, why do we need a principle of respect for autonomy? It's because we don't have respect for autonomy. I mean, these are all just signal flags for how far away we are from where we need to be. Sorry, David, go ahead.
We have no principle of respect for gravity. It's taken for granted.
Right.
So the notion, both the organizational notion and the ethical notion that Danielle describes, is the notion of value-based purchasing. That is, dollars should be spent to produce good health outcomes, not to produce treatments and diagnostic procedures and other sorts of interventions. And the notion of accountable care, that what employers or individuals should be paying for is to be kept healthy, and that should be the incentive. But mind you, all of these incentives have positive and negative consequences, both clinically and ethically. So the fee-for-service system is built on the notion of incentivizing over-treatment. The notion of value-based care or accountable care is built on the premise of under-treatment. That is, financial rewards if you spend less money on the patient. That's not to say that everyone will withhold necessary care, but there is that incentive built into the financial structure that we have to be careful of. The same, by the way, with our earlier example of the Hobby Lobby decision. That decision can be in part a religiously grounded decision, which under the Supreme Court's decision gives it enhanced legal weight, but those same kinds of decisions can be economic decisions by an employer who wants to spend less money on their employees' health care. And that will be particularly true if the employer considers certain kinds of health care, like birth control, to be morally suspect to begin with. And by the way, another shameless plug, if you want to hear more of a rant on the Hobby Lobby decision, I would direct you to voicesinbioethics.org, the online journal of the Columbia University Bioethics Program, where I have a complete two-part rant on how absurd is the outcome and the foundation for the Hobby Lobby decision, which still enrages me.
Great. Thank you, David. Thank you, Danielle. I want to follow up on this notion of the patient. So Guy Pear from the UK asked that in the context of, he mentioned this great discussion about the hierarchy of power in clinical contexts. And he's wondering if we will ever move away from using the term patient, namely one who suffers. And do you believe that there might be need to move away from that term, especially in the context of end-of-life care, end-of-life planning, and this notion of the completed life?
Danielle, you go first.
Yes, I hope so. I deplore this term, and that's why I'm always doing these annoying scare quotes around it and trying to talk around it. So among the Oxford English Dictionary definition for patient are the following, quote, enduring pain, affliction, inconvenience, etc., calmly, without discontent or complaint, forbearing, long-suffering, tolerant of the faults or limitations of other people, undergoing the action of another, passive, a person or thing which undergoes some action or to which something is done, a passive recipient, chiefly in contrast with agent, an entity that is directly affected or changed by the action, or in the grammatical sense, still in the OED definition, an entity that is directly affected or changed by the action of a verb, such as the object of a transitive verb. So it's embedded within the term is that this is the passive figure. And it's hard to change that without changing the language. David, what do you think about this?
You know, I am fond of saying that the world will be a better place when there is no work for doctors and no work for lawyers, meaning that we have gotten back away from the healthcare delivery system and the legal system being so complicated that people can't advocate for themselves or make decisions for themselves. And, you know, with the advent of artificial intelligence, we might get there. I personally have my fallback career as a carpenter, so I'm not worried about this. But the notion that individuals who receive medical treatment from others versus self-directed treatment, and the notion that that status has to have a word attached to it called patient, is a concession that things have gotten complicated, and that there has been the power shift that Danielle described in the definition of patient from the Oxford English Dictionary. I'm not familiar with the acronym OED, but now I am. And that's something that we should at least be aware of and recognize as something that may be necessary now, but is not either a norm nor an optimal mode of dispensing of care, because we have within our capability the empowerment of individuals to be more a partner in their treatment decisions. In fact, the question very much reminds me of the debate that has been going on, God, for at least 20 or 30 years about whether we should refer to people who are the subjects of medical research as participants or subjects. And each of those words is incredibly loaded, just as the word patient is incredibly loaded. The notion of somebody being a subject has the unavoidable connotation of them being a passive recipient of experimentation, which is all too often accurate. The notion of describing someone, so we talk about researchers, I like to talk about the people that get researched on as researchees, because I don't like subject. It's abusive. I don't think we have earned the right to call them participants, because they are in fact not active participants in the research endeavor, although in some cases they both could be and should be.
Well, and if I can just add to this collaborative rant that we're engaged in, even in cases where it's rare, but there are cases where the author of a research study is also the subject of the research study. And a famous example of this is the Nobel Prize winning work of Barry Marshall and Robin Warren, and they're documenting the role of Helicobacter pylori in gastritis and peptic ulcer disease. And so Marshall famously ingested this Campylobacter, resulting in gastritis. So he's actually the co-author of the case report, but he's not identified as such. And so this speaks to, David, what you're saying is that the subject of the research study, even if that subject actually is the co-author, they have to be separated. The form will not allow them to be the same. So in the case report, he's referred to in the third person as a volunteer and as the subject, as in, quote, the subject was irritable and appeared ill during the second week of the experiment. Several colleagues observed that he developed putrid breath. So we, the rhetoric, the form and the rhetoric of the field is adamantly trying to keep these roles apart.
And by the way, it speaks to the dispute that broke out at the time of the Schlöendorff court decision in 1914. Think about 1914. People were driving around in Model T Fords that had no doors and had a canvas top. And even then, the notion that patients should have some say, some providence over their bodies was, as I said, considered heresy. And so it's not surprising that the label of patient has both assumed and reinforced the notion that the patient is not in charge.
Great, thank you both so much. So we are just about out of time. And thank you so much to our incredible audience for such insightful and interesting questions. I've really enjoyed this fascinating conversation, so thank you both. I'd like to welcome you both to give a 1-minute concluding remark before we wrap up the session today. So David, why don't you start?
We can do better. We can always do better, right? I like to describe any effort at improvement of any system, whether it's in healthcare or bioethics or manufacturing, anything, as the effort to travel half the distance to the door. If you travel half the distance to the door, we all know you'll never get through the door, but you can get very close, maybe close enough to be able to peer through. That's what we're trying to accomplish. And so when we talk about the role of narrative medicine and narrative ethics as a tool or set of tools to redefine the standard of care, really what we're talking about is incremental, incomplete change that will get us closer and closer to a desired goal, the goal being to define care that is more sensitive to patients' needs and desires, so that they are accomplishing what this whole conference has been designed to accomplish, and that is to enable people to define for themselves a completed life.
Thank you, David. Danielle?
Yes, to all of that. And I hope that that this conversation does provide a little bit of hope, in the sense that there are these fields, groups of people who have been doing this work for a while. They have slightly different names. So in this case, we're talking about narrative ethics, narrative medicine, allied with many different movements, patient-centered care, the biopsychosocial model earlier, relationship-centered care. I mean, there are lots of different names out there. It can get very confusing, but the hopeful part is that there are many people, many talented people who have recognized that we need to do this work. And hopefully it's a benefit to see, oh, well, actually, there's this whole field that's developed that can provide some tools that are really going to help move us forward with this. And so I hope that we can leave off with a note of hope. I feel hopeful, albeit humble in the face of what we need to accomplish. And I just want to thank you, David, and you, Sarah, and everybody else involved in making this possible. And I look forward to continuing the conversation.
Thank you both again so much. So for everyone in the audience, a gentle reminder, if you are interested to read more about what our brilliant scholars have discussed here today, if you haven't already, please go ahead to our website to review the session materials for session 5. There are also other session materials available for previous sessions, and for our concluding session 6 next week, there will be further materials available here. So this is a valuable link. So completedlife.org / the URL, as you can see, Completed Life Conference Fall 2020 session materials. Please feel free to tag us on social media, #CompletedLife. We're on Twitter, we're on Facebook, we're on LinkedIn, so please reach out and say hello. We'd love to hear your thoughts on the session. Please also take advantage of our Slack discussion board and continue the conversation. So thank you again so much. And we'll be delighted to welcome you back for the 6th and final session of the inaugural Completed Life Conference next Thursday, October 8th, same time, same place, where we will welcome Thaddeus Pope and David Grunwald in their presentation on voluntarily stopping eating and drinking, or abbreviated as VSED, and how VSED at the very end of life can be an effective method of hastening death. And Thaddeus and David will explore the ethical and legal implications, as well as the clinical medical implications of VSED. So thank you so much. Please stay in touch. #CompletedLife again. And thank you again. A round of applause to David and Danielle for a brilliant presentation on narrative medicine and narrative ethics.